Dr. Robert Glatter from Medscape Emergency Medicine. As the curve begins to flatten throughout the country, we know that there are certain states, in fact, up to 26 of them, as according to data this morning, where cases are rising. And this is certainly concerning. So I want to bring in a panel to discuss this. I'm going to welcome first Dr. Megan Rainey. She's Associate Professor of Emergency Medicine and Public Health at Brown University, along with Ali Raja. He's Associate Professor of Emergency Medicine, also Executive Vice Chair at Mass General Hospital in Boston, Massachusetts, part of Harvard Medical School. Welcome, guys.
Thanks for having us, Robert.
Absolutely.
Thanks a lot, Rob.
The Northeast is better, but certainly we're looking at, a problem here in 26 states. Sometimes, I guess part of this is due to data reporting according to CDC guidelines. But, Megan, I want to start with you and get your thoughts on this. And are we headed for a second wave pretty soon with this data showing what we see?
Yeah, so Robert, we're certainly still seeing new hotspots pop up across the country right now. There are a lot of challenges in identifying when and where those appear, because we obviously have some states that are ramping up testing and others that are ramping down testing. There's uncertainty about the accuracy of the reporting of both cases, hospitalizations, and deaths that make it tough to trace. As we reopen, we suspect that we'll be seeing more infections, but there's one thing that may protect us over the next couple of months. It's that, of course, it's the summer. And so we're spending a lot of time outdoors. There's less kind of inside close quarters activity. So although we are preparing for a second wave now, we're suspecting that there will be smaller hotspots over the summer and that the true second wave will hit come fall.
Right. What role do you think the protests will have? I mean, certainly from a public health standpoint, they're outside and people are wearing masks. And then we can talk about some other issues regarding, crowd control agents. But are you concerned just by that fact alone?
I mean, obviously, it would be ideal to not have people outside in close quarters to each other.
Right.
But the issue of structural racism is a major health issue and obviously is deeply intertwined with COVID-19. I'm encouraged by the fact that most protesters are wearing masks. I'd like to see the police wearing masks too. And obviously, the more that we can maintain social distancing, the less that protesters are exposed to things like tear gas, then the lower the incidence of infections from these protests will be. It's going to be a sad but interesting experiment to see if and to what degree infections do go up after these protests.
Ali, I want to bring you in. What are your thoughts on this? Would you agree with Megan in principle on what she's saying? Do you have any other additions to the discussion?
Rob, in general, I would be foolish to disagree with Megan on just about anything. But in this case, I absolutely do agree with everything she said. It's interesting because, as she said, we're not yet seeing a second wave. What we're seeing is a very prolonged first wave as we see areas that maybe weren't hit as hard early now finally see the COVID cases that we've all been concerned about. In New York, in Providence, in Boston, where the three of us work, we saw cases months and months ago and we went through our surges. But now we're seeing places like Nashville, we're seeing places in rural Western Massachusetts or upstate New York or places in Texas that maybe thought that they would be able to get out of this, now seeing the surges in cases that we knew were coming, but were just delayed. So like Megan said, we're still probably going to see a second surge later this fall, but that's not what we're seeing now. We're still seeing the first surge in a lot of these places. The second thing is, in terms of the rallies, we've seen some really outstanding rallies. I was at one at our hospital just a couple of days ago, and mostly, at least those that I've been part of and have seen that have involved healthcare workers, have all been great about covering their mouths with masks. What we haven't seen a lot of, though, is a lot of eye protection. And unfortunately, given the close contact, I've been telling my patients who have told me, or our residents who have told me that they're going to go to one of these rallies, that really we need to be doing as much to protect ourselves as possible. And in such close quarters with a lot of yelling and screaming, understandably, well-deserved yelling and screaming, there needs to be much more protection given the potential for aerosolization. Now, we're outside, that's a lot safer, but when we're shoulder to shoulder, there's still risk that we need to try to mitigate.
And that brings us, full circle, Megan, to, we need to get out there and we need to embrace the spirit of what's going on talk about the issues of structural racism. Can you mention this and bring this into the discussion and really define what this means?
What does structural racism mean? It's basically the way in which our society has been set up to systematically disadvantage Blacks and other minorities. It's things like unequal access to housing, the old practice of redlining, where loans, mortgages would not be given to Blacks or other minorities who lived outside of a certain red line. And so therefore essentially segregated minorities, even in areas that were not officially segregated. Philadelphia is a great example of this. It's about the fact that Blacks and other minorities are more likely to hold those essential worker jobs, which are often unpaid, often don't have sick leave, often don't come with adequate insurance, more likely to be exposed to people who are sick, and then because of those housing inequities are more likely to live in crowded circumstances, and so not able to social distance from others in their household. It's about just, if you look on Twitter right now, there are threads with the hashtag Black in the Ivory that talks about the ways in which structural racism affects our Black colleagues in academia and in medicine. It's about all of these things that, as someone who is white, I don't think about every day, but that impact the daily lives and opportunities and choices and health consequences for minorities in our country. The fact that maternal mortality is, exponentially higher for Black women than for white women, even when they're treated at the same hospitals. So all of those factors play into it, increase the risk of catching COVID-19, likely increase the risk of we know that there's an increased risk of dying for Blacks, somewhere between 2 and 4 times more likely to die if they catch COVID-19 than a white person. And it's all plays in together. Access to healthy food. I could go on. And so as we're talking about how to change those patterns, we have to talk about those structural factors that impact disease prevalence and disease severity. It's not because of genetics, it's because of the way that our system is set up.
Right. I think this is one of the first times, certainly in my life, many of our lives, where we've seen the convergence of 2 large issues. And I think at this point, it's really quite a wake-up call to everyone in society. Would you agree, Ali?
I would. And, we had been talking about this for many months in terms of the racial disparities in the treatment of and the prevalence of COVID in some of the areas of Boston, for example, and I know this was just as true in New York and in Providence, where some of the hardest hit communities were those who already had exceptionally poor access to healthcare and were forced to go to work their jobs because they didn't have much of a choice. They couldn't stay home at work because their typically lower wage jobs required a physical presence. And so they were putting themselves at risk, getting hit harder, getting COVID more frequently, and then not having access to the care that other more affluent communities might have had. So we were already talking about this a little bit. And then, unfortunately, we saw this, no, we didn't see it. We recognized this wave of Black deaths due to police that have been going on for a long, long time, but have just really hit home more recently. And it's right, it's this convergence of 2 factors. And I think Megan brought up a really good point in that those of us in ivory towers and in medicine especially are not immune to this at all, despite the fact that some of us might think that we are. And in terms of our patients, our specialty, it happens that while you do a broad Medscape podcast, videocast, this is 3 emergency physicians speaking. Our specialty, one that caters to every patient for any problem at any time, is definitely not into this either. There have been hosts of studies that have looked at disparities around racial lines for pain control for orthopedics issues, patients going and getting cardiac caths for their chest pain. We've done some internal reviews looking at disparities in physician orders of restraints of patients. It's all there. We are not at all immune, and we need to recognize it and focus on fixing the problem without thinking that it's external to the world of medicine and emergency medicine.
Absolutely. I'm in complete agreement with both of you on this. I wanted to move on to another topic about PPE. And obviously that hasn't been in the headlines quite as much, but it's certainly still there. And obviously both of you are part of a very large organization now that's really doing incredible amounts of good in getting PPE. So it's hashtag Get Us PPE. And Megan, obviously this has been such an incredible effort. I wanted you to discuss this with us, where you are, how things are going, and your sort of success stories in supplying healthcare workers and healthcare systems with PPE.
Yeah, so this was a grassroots effort that started in mid to late March. Ali actually introduced me to Dr. Shuhan Hay, who is a colleague of his at Mass General, who had put together a website. I'd been doing work kind of externally trying to get PPE to frontline healthcare workers. Shu created a website, and then we brought together this grassroots coalition of software developers, physicians, nurses, med students, who came together to create this organization. We're a nonprofit. We are focused on getting donated protective equipment in the hands of frontline workers across the country. And in the past, although we didn't really track our donations in the first month or so of our existence because we thought we were going to be a short-term solution, since we started tracking, we know that we have delivered well over 1.5 million pieces of protective equipment to healthcare workers. And again, that's a vast underestimate because there's a lot that has been delivered that just wasn't tracked in those early days. We are working on delivering the PPE according to metrics around fairness and some of the very discussions that we're having now around how certain populations are more likely to be affected and less likely to have resources for protective equipment. And we're looking at not just the needs of hospitals, but also nursing homes, skilled nursing facilities, et cetera. One of our greatest strengths is that we work with a number of partner organizations and regional affiliates. So for instance, our Chicago affiliate, Get Me PPE Chicago, which is run by a med student, has just done tremendous on the ground work in terms of assessing need and helping to facilitate the donation of PPE to hospitals in need. And the thing is, Robert, we didn't think we would still be around. I remember in the very early days, a group had offered to do a bike ride to fundraise for us in mid-April. And we said, oh, we're not going to need, no need planning it for mid-April. We'll be done. Someone else will have taken over this work. Well, here we are now, mid-June almost. And now we're planning for what we're going to look like when the second wave hits.
That's incredible. And you brought up, we've been talking about disparities, but this to me strikes about disparities with PPE, price gouging, competition between hospitals, states competing for PPE. It's all in the same theme.
As you said, Robert, this has exposed yet another inequity, right? I have to say, as a physician who is part of the largest healthcare system in Massachusetts, we've actually been okay. Now, don't get me wrong. I don't want to underemphasize the work that the team at Partners, which runs Mass General and the Brigham, has done to pull up PPE supplies from everywhere they can think of. But quite honestly, we're an 800-pound gorilla and we can get that PPE. And so we've never run short on it. But there's a lot of organizations around the state and definitely around the country who haven't been able to do that and don't have the PPE that they need. And it's shown that additional inequity between the have and the have-not systems that really require and call out for a more central governmental way to distribute PPE and stockpile PPE that will make sure to equitably distribute the PPE rather than having the very large healthcare systems be able to get it and the smaller healthcare systems and hospitals not be able to, simply because of their size, despite the fact that they serve these communities that really, really need them.
Right. It's incredible that the national stockpile, was so depleted. And here we are, having to, build it back up. It sounds like it's back to some level of normalcy, but I think your organization certainly could play a role with the national stockpile. Megan, have you had discussions to that effect at this point?
So we've certainly had discussions with folks across many levels of government. I would love nothing more than to see our work be taken over by FEMA or HHS. Part of the trouble is that strategic national stockpile is not designed to fill the needs of all of these facilities across the country. It really is designed for a time and geographically limited disaster. So I think one of the things about this pandemic is that it's challenging everything that all of us always thought about disaster management, and is causing a lot of us in the academic and the medical world to rethink, as well as the humanitarian world, to rethink how best to plan for the next phase of this pandemic, which is national. One of the things that I've taken away from this pandemic, Robert, is the degree to which we as individual citizens can create solutions independently and create hope. Would it be ideal to have it run by government? Sure, but for now, it's on us to do this work.
Absolutely. I want to thank you, Megan. Thank you, Ali. This has been an incredible discussion, and I think our audience would truly appreciate this.